All right, physiology peeps, get ready for lecture 5 on cardiovascular physiology, the last lecture on this, and we're going to be talking about blood physiology. Okay. All right. So let's start with body water balance. Okay. Where you take water in or how and how you lose it. So pretty much the water that we take in comes from whatever we eat or drink. So that can be anywhere from 1 to 1.5 to almost 2.5 liters, depending on your activity level. All right. So we don't really absorb water across our skin like amphibians or something like that. So you can immerse yourself in a bath and you might absorb a little bit of water through your skin, but that's really not where you get most of your water. You have to consume it. All right. And that's a good time for me to hydrate right now. All right. Ooh, that's good. Okay, so let's talk about the main ways that body water is lost. And as the previous lectures talked about, when I talked about, I think it was lecture 3, regulating blood volume and blood pressure, your kidneys are number one. They are what regulate how much water you retain and how much you lose. So you could lose anywhere from 0.5 to 1.5 liters of water, depending on your state of hydration. Now, sweating is also a pretty significant source of water loss, almost up to a liter, depending on your activity. If you're running a marathon, you're going to be sweating a lot. Okay. Now, your lungs, anytime you exhale, water vapor from your lungs is escaping. And so you can lose a little bit of water from there. And then lastly, you can lose a little bit from feces, especially if someone's got diarrhea, they're losing a lot of body water. Okay. So, my question, since we've talked about how the body regulates blood volume and blood pressure, what hormone can increase water retention by first increasing salt retention, and then by retaining that water, your blood volume and blood pressure go up? All right. So, if you remember the hormone that has the letters for salt in it, aldosterone, you'd be correct. Okay. Now, that is a hormone that is secreted when your blood pressure is too low. Now, B, decreased water retention by increasing filtration rate so you pee out body water. This hormone is one of the long fixes, and it's secreted when blood pressure is too great coming into the heart. It's a 3 letter acronym beginning with A. A and P. All right. Okay, now this other hormone can increase water retention so that blood osmolarity can be reduced. So the goal of this hormone is not to fix blood pressure, but to fix blood osmolarity. It's also a 3 letter word that begins with an A, and that would be ADH. Okay, so these are all hormonal fixes that affect what the kidneys are doing. The first two are secreted when blood pressure is not correct, and the last one's secreted when blood osmolarity is not correct. Okay, so we've covered basically water balance. Now let's move on to blood physiology. So blood is made up of a liquid portion called plasma, okay, in which things are dissolved like salts, hormones, proteins, and a bunch of other things. Now, whole blood is the liquid portion or the plasma along with the cellular portion. The cellular portion of blood is red blood cells, which these red discs right here, white blood cells, which are these things with the little nuclei, segmented nuclei in them, and platelets, which are the really, really tiny things. And what we're showing in this image on the bottom left is if you take a blood sample and put it in a blood tube with like a vacutainer tube, and if you were to spin that with centrifugal force in a centrifuge, what's going to happen is the lightest substances like plasma is going to go to the surface, and then the heavier substances, which are red blood cells because they contain the iron in them, okay, in the heme, they go to the bottom. And so these layers will separate out. Okay, so let's talk about blood volume since we were talking about water intake and loss. If you were to calculate, someone came in and they're 80 to 85, well, I have it right here, 70 kilogram, a 70 kilogram man. Okay, there's my trusty calculator. All right, you could use your phone. What would be his blood volume range? Well, I'm not going to do a range. I'm just going to say, let's take normal blood value. Blood volume should be 80 to 85 milliliters of blood per kilogram of body weight. So to calculate the lower range, you would take 70 kilograms times the 80, and you get 5,600 milliliters. And if you divide that by 1,000 to put it into liters, It's 5.6 liters of blood. Okay, so a 70-kilogram man at the lower end of this range should have about 5.6 liters of blood. All right, and if calculated the upper range, it'd be 70 times 85, and that would be it. Okay, so that is how you'd calculate someone's blood volume. Okay, so let's move on since it's blood physiology and talk about blood cells. So, what we've got are white blood cells, red blood cells, and platelets. So, the red blood cells are these down here, okay? They're smaller than white blood cells but bigger than platelets. White blood cells are called leukocytes, whereas red blood cells are called erythro. Erythro means red, whereas leuco means white. So, they're literally calling them red cells versus white cells. So, white blood cells include neutrophils, eosinophils, basophils, lymphocytes, and monocytes. And lastly, platelets are called thrombocytes. Okay, so we're going to take these one at a time. So red blood cells carry hemoglobin, and hemoglobin, well, it's basically the pigment that's going to hold on to oxygen in your bloodstream. So your red blood cells carry oxygen bound to hemoglobin, and the hemoglobin is made of a heme unit plus iron, and we produce new red blood cells every single day because they only live for about 120 days before they're removed and destroyed, and parts of the red blood cells are recycled for use. So, heme gets broken into bilirubin, which is a yellow pigment, and the liver removes that yellow pigment from your bloodstream. The iron in the hemoglobin is simply recycled to make new red blood cells. So, what's the significance of me telling you this? Well, people who appear jaundiced, the whites or the sclera of their eye are yellow, and their skin and mucous membranes, meaning like their gums, are yellow due to liver failure. And there's many reasons for liver failure. But if someone comes in and their skin and their eyes are yellow, they are admitted to the hospital because that's liver failure. Now, the reason they turn yellow when the liver is not working is the liver is supposed to remove bilirubin that is released regularly when red blood cells are destroyed. And so, if the liver can't do its job, the bilirubin remains in the bloodstream, turning someone yellow. Okay? Now, um, erythropoiesis is the term by which the body makes new red blood cells. These red blood cells are made in your bone marrow. Okay? Now, the hormone erythropoietin released by the liver or the kidneys stimulates the process of new red blood cells being produced. And like I said, you're producing millions of new red blood cells a day. So erythropoiesis is happening every day. So the stimulus for the production of new red blood cells is actually lowered blood oxygen. So when that is sensed, the liver and the kidneys will respond by producing and releasing into the bloodstream erythropoietin. Erythropoietin goes down to the bone marrow and stimulates the production of new red blood cells. And that process from start of maturation to release of those red blood cells into the blood is about a 2-week process, but it's going on all the time. When there's more red blood cells, there's more oxygen carrying capacity, and so oxygen goes back up. Okay, so it's a little pathway. Okay, polycythemia is the term given to higher than normal red blood cell count. Now, what could cause that? The most common explanation is perhaps someone's a little dehydrated and the water content or the plasma content of their blood is a little lower, making it seem like red blood cells are more concentrated than they are. Anemia, on the other hand, is a lower than normal red blood cell count. And I got a clinical app that goes through all of these. And if we look at it really quickly, we'll make that big. Okay. All these forms of anemia I'm going to cover, but it's in a clinical app. So let's look at it. So, iron deficiency anemia is low iron in the diet, and women are more prone to this because they menstruate. And when you menstruate every month, you're losing blood and you're also losing iron. And so this is easy enough to be fixed with iron supplements in the diet. Okay, pernicious anemia is you're not getting enough vitamin B12 in your diet because you're not absorbing it enough. And you need that in the process of making red blood cells. So, again, this is an easy fix with the dietary supplement. Aplastic anemia, on the other hand, is not an easy fix. You see this when people are going through chemotherapy, not so much radiation anymore because radiation has gotten very direct, very particular. But chemotherapy is basically A drug that kills rapidly dividing cells is put into your bloodstream, and it does not tell the difference between rapidly dividing cancer cells and rapidly dividing blood cells, okay, like red blood cells or even white blood cells. And that chemotherapy can destroy those red blood cells, leading to aplastic anemia. And there are drugs meant to help people who are going through chemotherapy keep their red blood cells higher. Renal anemia is when your kidneys aren't producing enough erythropoietin and you don't get enough new red blood cells being produced. Fortunately, there are synthetic erythropoietins that can be taken. And then autoimmune hemolytic anemia. I'm going to talk about that more a little bit later, but that is where the immune system attacks red blood cells, and that happens with Rh disease in pregnant women. So we'll talk about that a few slides ahead. Okay, the blood typing system. The blood typing system is basically made up of the sorry, not the RBC, the ABO blood typing system and the Rh system. So if you are blood type A, you're blood type A because you have A antigens on your red blood cells. That's what identifies them. That's what makes you blood type A. Now, if you're blood type A, you make antibodies against B cells. All right. So a person who's got type A blood can only receive type A blood, or as you'll see, type O. They can't receive any B blood because they have antibodies in their bloodstream that would attack that blood. So they can only receive A or O. If you're type B, you're type B because you have B antigens on your blood. So you will also make antigens against type A. So you can't ever receive A blood. You can only receive type B or O because they don't have any A antigens to which this person's anti-A antibodies would react. Now, if you're blood type AB, you're lucky because you're the universal recipient. You have both A and B antigens on your blood, and you don't make antibodies. So you can receive any old blood type you want. Uh, it is the most rare blood type, but you can receive any blood type whatsoever. Now, if you're blood type O, you have no A or B antigens. That's what makes you O. And you have anti A and anti B antibodies, which means you can only receive type O blood. Fortunately, type O blood is the most common blood type that we have. Okay, now the Rh factor. If you have an Rh antigen on your red blood cells, you're Rh positive. If you lack the antigen, you're Rh negative. It is far more common to have the antigen, 85% of the population, than to not have it. So let's practice blood typing. Okay, so agglutination. In a blood typing test, it's a little card. Oh, look, I happen to have them with me. Okay, let's look. Here is a blood typing card. Okay, it's got, let's see, oh, upside down. Sorry about that. Okay, here's the blood typing card. Here's the A well, the B well, and the Rh well. And what you do is you'll be putting blood into half the well, all right? And then you put antibodies against the A antigen here, antibodies against the B antigen here, and antibodies against the Rh factor here. And you mix them up with a toothpick. And then you look for agglutination in these wells. If agglutination happens, it's clotting or clumping of the red blood cells. The antigen on the red blood cell is reacting with the antibody made against them. If you have a reaction, agglutination in the A well, it means the antibody reacted to A antigens that are on your blood. If you react to the B antigen, that means you must have B antigens in your blood. If you react to the Rh antigen, you must have Rh antigens on your blood. Okay, so let's see what that looks like. Here is a well showing in the A well, B well, and Rh well, showing that no reaction, the blood is smooth, versus agglutination in the Rh well. So no antigens for A, no antigens for B. That does mean O, and they would be O positive because they're positive for the Rh factor. Okay, what would this one be? There's no reaction, right? So it's still O, but now since there's no Rh, it's O negative. You get how it goes? Okay, now we have a reaction in the A well, which means this person's type A. They don't have B antigens, but they do have Rh antigens, so they are A positive. Next, we've got A positive but there's no RH. All right, so it's A negative. Okay, see where this is going, right? Now we have no A antigens, but we have B antigens, so they are type B. They're positive for the RH, so they're B positive. And then you have B antigens, but no RH antigens, makes you B negative. And lastly, AB. You have antigens in both the A and the B well, and the RH. That makes you AB positive. And then you can have AB negative. Okay? So anyway, when you're looking at the PDF of the PowerPoint online, you can click on a YouTube video of me of actually running a blood typing test. But we're not going to do that here in the video to save time. Okay, so let's talk about RH incompatibility in pregnancy. What happens with that is if an RH negative woman, she is RH negative, is carrying an RH positive child. All right. Now, if she's married to a man who is RH positive, that means 50% chance that the baby is RH positive. Now, during childbirth, if there's any mixing of maternal and fetal blood, sometimes childbirth is a bit messy, and there could be fetal blood that mom's body comes in contact with. That can happen during miscarriage, tissue tearing during childbirth, or a C-section. And what will happen is mom's immune system, if it detects those Rh positive antigens on fetal red blood cells, her body, maternal body, will produce antibodies against that Rh antigen within 2 weeks. Now, it's usually not a problem for the first child, but in her second pregnancy, if she again carries an Rh positive child, her antibodies against Rh could cross the placenta and attack the fetus's red blood cells, leading to autoimmune hemolytic anemia. Autoimmune means it's an immune response. Hemolytic means it's lysing red blood cells, and anemia means loss of red blood cells. So it could be fatal for the second child. Okay, it's not going to harm mom, but it could harm mom's child. So what happens if the physician or physician assistant suspects that mom's blood has come in contact with fetal red blood cells? They give an injection of anti-Rh antibodies. So here we have anti-D immunoglobulin. These are antibodies made in a lab, and they're given to mom. And if these antibodies find any fetal red blood cells that have Rh antigen on them, it's going to destroy them. Well, actually, it'll cause agglutination so that mom's immune cells come and destroy it. And this is to prevent mom's immune system from detecting this antigen in her body and forming her own antibodies. So it's given prophylactically. Okay, so let's go on to white blood cells. Okay, so in white blood cells, we have what's called granulocytes versus agranulocytes. Agranulocytes are white blood cells that have granules in the cytoplasm. That includes neutrophils, shown here, eosinophils with a nice pink purplish granules, and then basophils with very dark staining granules. You see, neutrophils are the most common white blood cell in the bloodstream, and they're the first responders, kind of like paramedics to the scene of an infection. Eosinophils are less frequent, and you see those with chronic inflammation, allergies, and parasitic infections. Basophils are very unusual, and they're the ones that produce the histamine in an allergic reaction. Remember, we talked about that with anaphylaxis? Okay. Agranulocytes are white blood cells that lack granules, and they include monocytes, these very big cells that look like a half moon shaped nucleus in it, that are basically uh, phagocytic cells that find a pathogen and consume it and destroy it. And then lymphocytes are also pretty frequent, are part of your body's immune system, and they involve T cells and B cells, which we will talk more about when we get to the immune system. But in nursing, a common mnemonic device used for how to know which blood cells are found in decrease in frequency is never let monkeys eat bananas, which stands for neutrophils, lymphocytes, monocytes, eosinophils, and basophils. All right, so don't give those monkeys no bananas. All right. So since we've talked about white blood cells, let's talk about some leukocyte disorders. Now, leukocytosis is an increase in white blood cell count, and that, if you see on a blood panel, is indicative of an infection. Okay, so that's when you're starting to think about antibiotics. Now, leukemia is an increase in white blood cell count, but it's the number of immature white blood cells. So you will see this with the leukemia, the cancer. So what happens is the bone marrow is churning out white blood cells before they're mature. And so if you see a lot of immature white blood cells in the bloodstream, that's abnormal. And immature white blood cells cannot protect you well because they're immature. So that's kind of a hallmark of leukemia. And then leukopenia is decreased white blood cell count. And I'm going to fix this right now just because I don't think it's correct. It is not correct. I'm going to fix it. Um, I go to where I am. Here we go. Leukopenia. Okay. Chemotherapy treatment. That is more correct. Okay, so you'll see low white blood cell count, and anyone who's taking immunosuppressant drugs or are immunosuppressed like AIDS patients, or they're taking chemotherapy. Okay, and I had an image here of what immature white blood cells look like. Okay, so this image is what leukemia would look like. Okay, thrombocytes. And believe it or not, we're almost done with this lecture. Okay, thrombocytes are part of your clotting system for when you have a cut in the blood or a blood vessel. So thrombocytes produce thrombopoietin, a hormone, well, not thrombocytes produce it, sorry. The liver and kidney, just like they produce erythropoietin, they produce thrombopoietin, which causes platelet production. Now, platelets, here we see some with the arrow pointing at these little purple things in between all the red blood cells to show you how small they are. But let's look at clotting, okay? Hemostasis is basically stopping of bleeding from a damaged blood vessel. So what happens is the platelets will form a plug. And so over here you see platelets forming a plug to which red blood cells will stick or cause a clot. And then the platelets lead to the production of fibrin threads that kind of knit the wound together. So platelets convert prothrombin to thrombin. Thrombin activates fibrinogen, and then the fibrinogen converts into fibrin threads that literally knit the wound together and hold it closed. And so here's an electron micrograph view of platelets and the fibrin threads and the much larger red blood cells in the clot right there. So this is how blood stops flowing, hemostasis, and a clot is formed, which can then become scar tissue. So if someone has a clotting disorder, there are a couple of tests you can do. One is bleeding time, and you can prick the skin with like a little lancet, and it should clot within 1 minute or 3 minutes. Anything longer than that, you've got a clotting disorder. The other thing you can look at is prothrombin time. So you treat blood plasma, the liquid portion, with citrate and thromboplastin, add calcium, and measure the time for a clot to occur. If it's less than 12 seconds, it's okay, but if it's longer, there is a problem. All right. So there's a clinical app for clotting and anticoagulants, but I'm not going to show it in this video to save time. Okay. Now, if you're collecting blood for some of these tests, you have vacutainer tubes. All right. Now, I'm showing a whole list of them: orange top, red top, purple, gray, blue, another red, green, black. They all mean something. And this is a vacutainer holder, and this is a vacutainer needle. Now, so what these tubes do is they have a suction, they have a vacuum. All right. And once you put the needle in the vein, all right, and you start to see blood coming out, then you pop on the tube that has a rubber stopper on it, and then it will suck in the blood and fill the tube. The red top tube has no anticoagulant. So that just is blood put in a tube, and naturally that blood will clot on its own, or you can spin it, and the fluid that will rise to the top is called serum, and you can use that in serological tests or blood tests. The purple top has EDTA, anticoagulant. So this blood in the tube should not clot. You can spin this, and now the fluid that rises to the top will be plasma. Okay, you can also use this as whole blood for doing blood counts like red blood cell counts, white blood cell counts, or disease testing. Now, the green top has got a heparin anticoagulant, and that is used when you're doing blood chemistry panels. Okay, so that's just a quick intro to vacutainer tubes. Okay, that is a great place to stop for this lecture. The fifth lecture will be about hemoglobin and hemoglobin disorders. Okay, so I hope you enjoyed the fourth lecture in the cardiovascular and blood physiology.